for joining. We're very fortunate to have Dr. Neil Stollman with us tonight, who's going to be talking about C. difficile and fecal transplant, the beginnings of microbiome management. So Dr. Neil Stollman is currently the chief of the Division of Gastroenterology at Alta Bates Summit Medical Center in Oakland, California, and an associate clinical professor of medicine in the Division of Gastroenterology at the University of California in San Francisco. Dr. Stollman has written about such topics as fecal microbiota transplant for C. difficile infection, diverticular disease, eosinophilic esophagitis, and H. pylori transmission and treatment. He is a co-author of the ACG C Difficile guidelines and AGA EOE guidelines, and is currently a trustee of the American College of Gastroenterology. So we're very fortunate to have him speak tonight. And thank you so much for being here, Dr. Stollman.
Well, thank you, Leah. That was a very kind introduction. And thank you all fellows for being here. Some of you, of course, I know from Northern California. I presume some of you are Southern California folks, and welcome to you all. Yeah, that's a nice intro. I do a lot of stuff. I didn't realize I was that busy. And I will tell you, just for the fellows here, I think there's a little bit of a lesson there is, you know, I'm a working stiff, right? I'm a working Joe in Oakland, California. That's who I am. Yet I get a lot of shit done. And I think the entire secret to that is not being certainly better looking than anyone. And I don't think it's being smarter than anyone. It's really saying yes to stuff mostly. And it's saying yes and getting it done. And that's honestly, if anyone asks me where I got to where I got today, it's largely saying yes and turn it in on time. And I don't think it takes a whole lot more than that, honestly, to do well. And I wish you all well. We are going to talk, let me share my screen. So we're going to talk about poop today. Let's share that one, I think. Let's do that. Let's go to full screen. Okay, you guys seeing that? Well, I'm way up ahead, of course, but let's go back to the beginning. So we are going to talk about, and you guys interrupt me if you can't hear me or if I'm losing signal or if something's going wrong, just let me know. But we're going to talk about C. diff, the bug, and of course the treatment for C. diff, which is FMT or fecal transplants. And to all of us as gastroenterologists, those are important things because that's part of what we do. But I also think that's kind of the micro of this talk. I think the macro of this talk is different, and that's really the conceptual the concept that we can fix an illness with biome interventions, basically. And I think really this is in many ways the proof of concept of a successful FMT, of a successful biome altering procedure leading to health, basically. And I think that's a really important part of this. And I think there's a much bigger picture than just these few patients we have with C. diff. So what I'm going to talk about today, this is our outline for the most part. What I'm going to talk about, remove this out of my way so I can see here. What I'm going to talk about is sort of some intro to biome stuff, make sure we're all on the same page with semantics and terms. I'm going to talk a little bit about dysbiosis, a bad biome, although that's a latent term and not a very clear one. Then we'll, of course, segue into C. diff, which is important. I'm going to anthropomorphize a lot today, but which is important because it's really this opportunist that takes advantage of this dysbiosis, right? C. diff's all over the place, but can't really do much to you until you have a disrupted biome, and then it certainly can make you sick as hell. FMT, of course, is the problem solver in this particular case, the biome restorative therapy, and then hopefully I'll end rather with some thoughts and considerations about what the future might hold. So this for sure is the new thing. And this is just literally a PubMed search from January, from a few months ago, of intestinal microbiome. And one of the papers, I think I'll show you, I'm not sure, but my first paper on this was in 2010. It was 22 patients, our first open label series of 22 patients with FMT, 12 of mine and 10 from Chris Swarowitz up in Seattle. And that was really, believe it or not, that was the state of the science in 2010, 12 years ago. And obviously the state of that science has gone a lot further in that decade, up to literally 60,000+ fecal transplants from that first report of 10 of ours. And obviously an extraordinary body of literature now. So this is really a decade field. That's it. So you guys are all caught up. That's it. We are essentially caught up on that. And as you all know, of course, there's this insane mania. There's a really interesting scientist up at UC Davis named Jonathan Eisen, and he's a good Twitter follow actually as well. And John does basic science in the biome. But as a side hustle, he runs this little blog called the Microbiome Mania blog, and he gives an annual award that he calls the Overselling the Microbiome Award. And it's not hard. It's shooting fish in a barrel. It's actually quite easy to find examples of overly aggressive biome promises basically. And here are a few of them on this thing here: your whole body, how to harness your microbes for lifelong health, how to heal your body from the inside out. That seems to be a theme, inside out. Biome, I think, is a problematic company that actually will assess your biome, and that's fine, but then we'll also sell you shit based on that assessment of your biome, and that's not so fine. The presumption that they're selling you a customized product based on your biome analytics is absolute nonsense. That's sort of the thesis they're working with. So I would caution you that there are far more claims about the biome today than there is science about the biome, despite all of that science. And there's even some crazy words here you should know. So we use the word, I think we use the word microbiome when we really mean microbiota, which is the bugs that live in an established environment. And that can be our colonic microbiota or skin microbiota or ear microbiota, whatever you want it to be. The biome is actually not the bugs, it's the genetic material of all of those bugs. But I think in sort of popular semantics, we tend to use it interchangeably, but precisely they're not the same thing. Dysbiosis is actually, I think, a problematic term because it implies that we understand what's good and what's bad in the biome, and I'm not entirely sure that we do. So some people have suggested we call it, in fact, a varibiosis rather than a dysbiosis, because dys has a connotation of negativity that I think our science isn't necessarily clear about. What we're clear about is an altered biome, but not necessarily a good or bad biome. And then we're learning more and more that it's not just the damn bugs, of course, it's the bugs do stuff within a soup and a milieu, and we call that the metabolome, the metabolic properties of our gut microbiota. So those are kind of some early semantics for you. And just to, you all know this, of course, because it's what we do for a living, but what is our poop? Our poop's about 3/4 water. That varies among our patients, but about 3/4 water, about 25% solid matter. And within that solid matter, about 1/3 of that is simply undigested food. Another 1/3 of that are some cells that are shed and secretions and mucus. And then about 1/3 of that are bugs. And if you want to do some numbers, in a gram of stool, which is certainly not a whole lot of bugs, there are literally 100 billion microbes. There are a lot of us. There's a wonderful book about the biome called I Contain Multitudes, which I think is a really apt title for that. So we're definitely not alone. There are literally not billions, but there are trillions of bugs collectively that live on us, inside of us, around us. And I say bugs, and I think colloquially think about bacteria, but to be very clear, our biome does not include bacteria alone. It includes viruses and fungi and phages and a whole lot of other things as well. And of course, there's not just, in the context of this lecture, in the context of most of your conversations with patients, when we talk about the biome, we really mean the gut biome or the colon biome precisely, but recognize that's not true. I mean, you have to be very mindful. When you say biome, that doesn't mean anything. There is a oral biome for sure, and there is an oral, A-U-R-A-L biome, and there's an O-R-A-L biome, and there is an underarm biome, and a skin biome, and a hair biome, and certainly a genital biome, and of course our gut biome. And just by numbers, there's more of them than there are of us. It's really that simple. If majority ruled, if we were defined by simply numbers, they're in charge, because there's more of them literally than there are us. Now, we of course have neurons and opposable thumbs, so we can do some stuff that they can't do. But in fact, numerically, there's a lot more of them than there are of us. And as I mentioned, it's not just sort of inside us, it's in fact on us as well. And we have a biome cloud that in fact, it has forensic utility. It is a unique signature. You walk around like Pigpen, if anyone's old enough to remember Pigpen on Peanuts characters, that little character walked around with this little cloud of bugs around him, and that, of course, is the Tokyo subway. Could be Bart too, but that is the Tokyo subway. We are a cloud of bugs, and in fact, your cloud of bugs is absolutely distinct and unique to you. You have a bug signature that can be measured, actually. And one day, we're going to literally do forensics in that. You're going to walk out of a room, and the cops are going to, NCI, whatever the hell, is going to come in, and some guy's going to be in a Ghostbuster suit. He's going to suck up some of that air, and he's going to know who's been in that room by their biome signatures. That is not as folly as it sounds right now. So I've thrown out these big numbers at you, but I want to highlight probably the most important thing that we know as probably true today, and I even highlight the probably of that. It's not just about the numbers, it's for sure about the splay or the spread, and we use the term diversity for that. We use the term microbial diversity, and in fact, we measure alpha diversity and beta diversity, and there's something called the Shannon Diversity Index. So diversity turns out to be a characteristic of our biome that in the very simplistic sense is arguably the one thing that you can look at to kind of define a good biome from a bad biome. And it's quite clear that more diverse biomes are associated with health, at least statistically, than less diverse biomes. And it's quite clear that when we take antibiotics, we constrict the diversity of our biome. And it's quite clear that when we do FMT or eat probiotics, we are expanding the diversity of our biome and in at least an intent to promote health. And this is just a tiny little study from 15 years ago or something about people who don't get C. diff, people who get mild C. diff, and essentially people who get recurrent C. diff. And not shockingly, those who do worse have a less diverse biome, and those who do better have a more diverse biome. And I'm going to come back to that again and again. That's not news. But I am right now, you're looking behind me at the gorgeous sunset and dusk of Oakland, California, which by the Herfindahl-Hirschman Index, and I know you all know what the Herfindahl-Hirschman Index is. There will be a quiz later. The Herfindahl-Hirschman Index, by the way, is a language diversity index. So it's a measure of linguistic diversity by population. So number of languages by number of people, in essence, is what it is. And in that entire country of cities greater than 400,000, most diverse city in America is not New York, which has more languages than us, but a whole lot more people than us. It is Oakland, California. So woot woot for those of us who are Oaklanders tonight. We have the privilege of living in and raising my children in and walking every day in literally the most diverse city in America. And I think that's fabulous, actually. If you want to know some names, and I'm not going to go through bug names very much with you today, but largely the two main bugs that are in our gut are in the phyla, Bacteroidetes and Firmicutes. And here, there's a chart there that I won't go through with you, but on the right is sort of the human correlates, right? We are in the animal kingdom, of course. We have spinal cord, so we're in the phylum Chordata. We are mammals. We are the order primates. We are in the family hominoids, and our species, of course, is Homo sapiens. If you do that with bugs, and you look up to the phylum, the main bugs we see are Bacteroidetes and Firmicutes. That is the large bulk of the bugs that live within us. And to be very, very, very clear, it's not a list of bugs. I mean, that's complete, utter nonsense to believe that the bugs in us are a catalog of 1,000 different organisms. They are 1,000 different organisms or 2,000 different organisms, but in no way in hell is that useful. That is to me exactly as if I gave you the phone book of the city of Oakland, which listed the 400,000 residents of Oakland, and you understood a damn thing about Oakland. You would not understand anything about Oakland other than those names. And that's really what we do when we list our bacteria. In fact, our bacteria are very much in niches and consortia. We use those words a lot, and they work together. They are very much codependent and very helpful to each other. We are not a bunch of lone rangers inside us. We are very much a wolf pack, and the bugs help each other, and the bugs help us, and we help the bugs, by the way. This is a really, really symbiotic relationship in most cases. We're going to talk about the case where it's not, but in the large majority of healthy people, this is a very important and very symbiotic relationship. It's only at the extremes where that's not true. So let's talk about our human biome. When do you get it, of course? Well, you get it essentially at birth. Your peripartum period is by far our first major exposure. And we've thought for a while, I'm going to show you something that may not jive with that so well, but we thought for a while that you kind of get your biome in the first couple of years of your life, and that's your biome. And you kind of live with your biome for life. And I'm not sure that's true, but that's been one of the sort of take homes for a while. And where do you get it? Well, you get it from mom, basically. You get it first when you pass through a birth canal and the vagina. So vaginal contact and skin-to-skin contact for a newborn is an extremely important source of biome exposure, as including mom's blood and breast milk, both of which contain bugs as well. And as you might imagine, cesarean sections deprive that newborn of some biome exposure. And that's part of the problem of cesareans. And it also might not surprise you to know that, as a very gross sense, children born via C-section seem to have an increased risk of some later autoimmune problems like allergies and infections and eczema and stuff like that. And one of the theses is that that's simply due to the fact that they're not getting sort of best possible early life biome exposure. And there's a really cool data set now where basically women who are laboring and are destined for a cesarean throw some gauze pads in their vagina for an hour while they're getting their cesarean. And once that baby comes out, take those gauze pads out and basically rub it over the kid immediately after. And that's being done routinely. And I think it's eminently rational. It's been absolutely demonstrated to colonize the kid and improve the kid's biome diversity. Now, whether that will lead to the kid getting into Harvard or not getting eczema in 20 years, I can't tell you, but I can tell you that you can colonize that kid and you can improve the diversity of that kid's biome simply by something as important as that. So, of course, birth matters, but then we grow up in a home and we have things around us, and there's actually a science that's referred to as the biome of the built environment. That is a legitimate field of study. And a lot of people, that the woman at UCSF works a lot on this. So the stuff around us matters too. And these are just kind of some fun facts about that. People who have, humans who have pets and livestock seem to have less allergic phenomena, like asthma and the like. Patients with recurrent C. diff who have pets get less recurrence than patients with C. diff who don't have pets. It's that simple. That is an outcome that has been demonstrated. Pets are a good source of biome diversity for us. Antibiotics in early life are a very poor thing for us, of course, and there's a fairly good correlation with early life antibiotics excuse me, and later health consequences, including obesity and asthma and the like. Farmers have great biomes. They have different biomes than city workers. Sailors' biomes change when they're land-based and when they go to out to sea. Lots of other things can do that, stress, sleep, all of this correlates with our biome. So it's not just what mom gave us, it's also what's happening as we grow up. Certainly our diet plays a role. And on the bottom right, I just showed you a sort of interesting take home. I got a puppy. I'm watching my son's puppy and she's next to me and she's having a fit right now with a sock. So it's all right, Lulu. She's having a battle with a sock if you hear any crazy dog noises. We are what we eat in some sense, and our biome, of course, does affect our diet, rather, does affect our biome. I was telling you how happy I am to be in urban Oakland with the diverse population here, and that's really good for the community around me. It's actually not good for my biome. I have a significantly less diverse biome probably than rural people and farmers and indigenous populations. Biomes can totally influence our appetite and eat and weight. When you move to this country, we're not very good for your biome. And in about 9 months, you start to become Americanized from a biome perspective. And that's not a good thing. You get less diversity. You lose some plant degrading enzymes, particularly Prevotella, and you end up with more Bacteroidetes. It is not a good thing necessarily for your biome to move here, but so be it. This is just because it's happy hour at 6:30 tonight. This is a really cool report last year that showed looking at different cohorts and biome diversity. Red wine consumption. So I'm drinking coffee right now because, well, that's probably the best thing for this. But some of you should be drinking a glass of red wine. And if that's your homework, you can absolutely justify it that your red wine consumption is increasing your alpha diversity. You don't have to do it every day. Infrequent consumption was effective. White wine's not as good. It's better than nothing, but white wine is not as good for your biome. And turns out I just got back from Scotland. Whiskey doesn't do a damn thing for so I was touring distilleries in the Scottish Highlands. I didn't help my biome very much, but so be it. Intimacy matters. I'd mentioned earlier that we think most people's biome kind of stays the same from youth, but turns out that may not be true. This is a kind of cool study where in Wisconsin, they basically took these couples, these families and couples, and followed them for 50, 60 years. There's tens of thousands of them. And it turns out if you live with someone, your biome, so that is the living with a spouse, leads to more biome diversity than if you live alone. If your biome was kind of set at birth, or at youth rather, as I mentioned earlier, you'd expect spouses to have more similar biomes siblings to have more similar biomes than spouses, but in fact, that's not true. You become closer, the closer you are to your spouse, the more similar your biomes become. And in my favorite result of this whole study, they asked the subjects to rate the strength of their marriage. That's not very subjective, objective rather. It's clearly subjective, and they gave them a 3-point scale. In essence, we are not close, we are somewhat close, or we are very close, and that was it. So you had those 3 choices. But those who were defined as very close or somewhat close had more similar biomes than those who were not. So the closer your marriage, basically the closer you and your loved one's biomes become. So that's something you can have pillow talk about tonight. You are sharing biome basically, and I think that's a beautiful thing. So So what is a good biome? I kind of mentioned already that you have a field guide, right? That's another concept. Imagine, of course, I gave you a list of every bird in the rainforest, right? Once again, that would tell you nothing except a bunch of names about the rainforest. You wouldn't know a darn thing about what that rainforest looks like. So we don't really entirely know what a good or a healthy biome is. This is my biome if you're curious, and you can spend some money and get someone to do this for you. The graph on the left is 7 years old. This was my biome in 2015 from a company called Biome that has since been put out of business by fraudulent billing, actually. So they were raided by the FDI and put out of business. Welcome to the wild, wild west of biome profiteering. And you can see I got a lot of Firmicutes and a lot of Bacteroidetes, and I got a gold star. Well, it's not gold, it's black, but I think of it as a gold star. So yeah, I had a good biome. And then I just redid that actually most recently to kind of see where things are going. And it actually isn't all that much different. I still have a lot of Firmicutes and a fair amount of Bacteroidetes. And this is kind of what my biome looks like. And that's nice, right? I have a graph and pictures and good colors. What does that tell me? Absolutely nothing. It tells me absolutely nothing. So if you want to spend $99 and get this graph, you can. I don't think it is actionable in any way, shape, or form today. You who are not yet in practice are for sure going to start being surprised when your patients walk in with their 87-page Genova doctor at GI maps, these incredible things that they spend a lot of money on with lots of graphs and pie charts they want you to interpret for them. But I will tell you, I don't think this is interpretable at all. So bugs can go bad, and we use that term, and there's a bunch of different ways they can go bad. Certainly what a bug can bloom. So for example, C. diff might be a commensal in me and you and those of us who work in GI certainly and hang out in hospitals. C. diff might be a commensal within us, but with a change in our ecosystem can overgrow or outgrow. So you can get a bloom, if you will, like an algae bloom, although it's your bugs, of course. You can lose good bugs, and that's what happens with antibiotics typically. And in fact, that's what an FMT does, is restores our commensals. That's the logic of an FMT. And it also absolutely restores our diversity. And as I mentioned to you earlier, you can't, it's really, really, really hard to draw any causal inference from biome analytics today. And by the way, there's an entire field now of biome stats. You want to go into statistics, you can be a biome statistician and with supercomputing do a whole lot of work to kind of figure out these associations. But right now, it is association, not causality. You can say that this population has more of bug X than that population, or that population has a higher ratio of this bug to that bug, but it's all just observational and inferential right now. We don't know anything about sort of outcome. And as I mentioned earlier, the term it's been suggested that we actually don't use the term dysbiosis, and then in fact we use this term varibiosis because we're fairly ignorant to really what bad in fact is. The presumption, of course, is that we know that, and that by taking a probiotic, you're going to improve your biome. You're going to fix your dysbiosis. And of course, that's what ultimately FMT is, right? If you think of it, FMT in a sense is sort of the ultimate probiotic, right? I mean, you eat some yogurt that has lactobacillus in it, you're taking one bug, your patient buys a little sachet of VSL number 3 and that's got 8 little bugs in it, or you buy some of X, Y, or Z and you got 4 bugs in it. But that's ridiculous, of course, that these 3 bugs or 5 bugs or 7 bugs are going to have the role anybody wants them to have in this dose at this time. And the AGA did a guidelines on probiotics a couple of years ago, and you should read it, but I'll summarize it for you. There's really not a lot of good evidence base to support the role of probiotics. There is some utility to actually Saccharomyces, which is not a bacteria, to be clear, it's a yeast. Saccharomyces cerevisiae, of course, is brewer's yeast or baker's yeast or one of those things. S. boulardii, a non-pathogenic yeast that has some benefit actually perhaps in C. diff infection or treatment. There's some role in pouchitis perhaps, or in prevention of necrotizing enterocolitis in preterm infants. But beyond that, there just really isn't a data set that supports the routine clinical use of probiotics, whether we want that to be true or not. Certainly your patients want that to be true, but it's simply not. That being said, we do think there are ways you can help your biome, and patients ask me this every single day, and they're certainly going to ask you that too. If you have a baby, breastfeeding baby is better for their biome, we think, than not breastfeeding. There's good data that a fiber-rich diet, basically in a sense, is there's this whole concept of prebiotics, and it's mainly marketing. It's bug food, right? You're giving a starch or a fiber source, which is what the bug needs to live, but the bugs live just fine on what's in you. But you can sell more probiotic apparently if you package it with a prebiotic, because it's all a narrative in your patient's head. Diversity of diet is better than a constricted diet, and a diversity, of course, of fermented foods, of living foods, kefirs and kombuchas and misos and sauerkrauts and unpasteurized pickles and unpasteurized sauerkraut and things like that. Those are great for our biome, we think. And I think I'll show you a study on that in a minute. Emulsifiers and processed foods are not good for our biomes. Sugars are probably not good for our biomes. Artificial sweeteners are almost certainly not good for our biomes. Antibiotics are very clearly not good for our biome. And animals are. So lots of pets in your house is absolutely, in addition to our mental health, I think is very important for our biome health as well. This was a really cool study, actually. This comes out of Stanford. So some of you may know Justin Sonnenberg. This is the Stanford group. And this was published in Cell just a few months ago, I think. 17-week randomized trial, relatively small, 18 people in each arm, and half of them basically got what we would always do with our GI people with any symptom, is throw fiber at them, right? That's been our mantra for decades, is throw fiber at people. So if you take these people and you give them, they had an average of 22 grams of fiber a day, you bumped them up to 45 grams of fiber a day, you didn't actually help their biome very much, as it turned out. The control arm, the other arm, got basically bombed with fermented foods instead of bombed with fiber. So yogurts and kimchis and kombucha, a lot, 6 servings a day. That's a lot of fermented foods a day. But in that group, diversity did go up. It did not go up in the high fiber group. And they've measured a bunch of inflammatory signals and activity, and they went down. Those things went down. So just in this kind of very simplistic study, but I love it because it, of course, echoes what I think is true. So we always like those studies. There's clearly a reporting bias here, but this fits with what I think is true, which is that probably, I mean, yes, people should eat a high fiber diet. It's a whole heck of a lot better than a low fiber diet. A lot of reasons for our colon and our cholesterol and our hearts, but I think a high fermented food diet is also very important for us. And I largely recommend that to my patients pretty aggressively. All right, so let's turn from foods and probiotics to actual bacteriotherapy and C difficile. So we're going to talk a little bit about C diff itself now. And as I mentioned, and you probably know, C diff patients often are the consequence of chemotherapy or antibiotics, both of which sort of constrict the diversity of their biome. They have a bad biome. C diff outgrows. And as proof of concept, they are absolutely curable simply not by killing the C diff directly, but by simply expanding their commensals and restoring their healthy biome. And that clearly leads to resolution of C diff. This graph on the bottom is from the CDC. I didn't make it up, but it's pretty. It's got skulls and crossbones and dollar signs and stuff like that. Bottom line is C diff kills people, causes a lot of badness, and costs us a lot of money. That's not a surprise to anybody. It is an anaerobic gram-positive spore-forming bacillus. Those spores are really important. The key to understanding C. diff really is to understanding that there are really 2 C. diffs in this world. There's the vegetative bacteria, which is actually quite easy to kill. And then there are these spores, which are the problem, which are really very, very challenging to kill. They can live outside of our bodies for a long time. They are hard to kill in the environment, and they are hard to kill in people. And that is why recurrent C. diff is a problem, because of this spore problem. I mentioned earlier that C. diff can be a commensal. I've not checked myself, but it wouldn't shock me. I take care of a whole lot of C. diff people. Wouldn't shock me that 5 to 10% of the world carry C. diff, and they are not ill from it. Some of us are probably in that 5%. And in fact, infants are born with C. diff, by the way. We don't test for C. diff in infants at all. It's a normal commensal in the newborn, and it is not pathogenic for them at all. Put someone in a hospital for 3 days, more than 2 days. Yeah, 3 days, a third of them will get C. diff, will get colonized. They won't get clinical illness necessarily, but hang out in the hospital for more than 3 days, and about a third of patients will get colonized with C. diff and hang out in a long-term care facility, and at least half of our patients there are getting colonized with C. diff. We're not just seeing it after antibiotics. That's obviously the dominant one, but we see it in peripartum patients, IBD, cirrhosis, other immunosuppressed patients. It's for sure the leading cause of nosocomial diarrhea, and it has a mortality. It kills our elderly. The mortality rate for C. diff in patients over X, I don't recall what X is literally 10%. So patients admitted to the hospital with badass C. diff can die. So take it seriously, of course. And then this is now a decade old. It's not new, but there wasn't a sort of mutated C. diff. You know, nowadays with COVID, we're getting mutants every week or month, but about a decade ago, an epidemic strain of C. diff occurred called the NAP1 or the BI strain, also called the 027 strain. And it's a mutation in C. diff that basically was a mutation in a toxin suppressor gene. So if you mutate a gene that holds toxin levels down, not shockingly, the bug makes more toxin. So it is a bug with a 10 or 20x fold greater toxin production, and not shockingly either, that makes people more sick. More toxin makes you more sick than less toxin. And as I mentioned, you have to kind of have a susceptible biome to get C. diff, usually due to antibiotics or chemo, but it doesn't have to be. And you have to get exposed to the bug, which usually is in a healthcare facility, but also does not have to be. This is a person-to-person bug. We give it to each other. It comes out of us, as you might imagine, below. It enters us, as you might imagine, above. And that is the pathway of this bug, with the caveat that I hinted at before, which is that those spores can live outside of humans for months, literally months, and they can be found on bed rails and toilet flushers and door handles and other touch surfaces in care facilities, and your home and my home as well. Those spores can hang out, you ingest them, you touch them, you get them on your hand goes to your mouth, you ingest them, and then the small bowel is nice and warm and moist and very hospitable place for them. Those spores go, yay, I'm home, and they germinate, they run down your colon, they multiply and piss you off, basically. That is, in essence, the life cycle of C. diff. There's some really cool work being done in a lot of places, but Jessica Allegretti at Boston is looking a lot at the role of bile salts in C. diff sort of germination and pathogenesis. It turns out that our bile salt profile may play an important role in that. That's just to tease you. That's not something we fully understand yet, but it's probably coming. I said a whole bunch of us can be colonized. And in fact, for most people who are colonized, nothing really happens other than you're at risk for getting sick later. So being colonized, again, I may or may not be, I don't know, but let's assume for a minute I am. That's not a problem necessarily unless I get admitted to a hospital and get antibiotics. And then I do have a higher risk of getting sick than if I were not colonized on entry, in which case I have to get colonized first. Some people get mild diarrhea. Some people, of course, get fulminant toxic megacolon and end up in an ICU and with colectomies. And those are the ones who die, actually. That's where the fatality rate is. And then what I deal with in my practice, much more so than toxic megacolon, is this population, this really big population of multiply recurrent disease. And that's where we're going to talk about FMT about largely, is this population of patients with multiply recurrent disease. And as you know, once you do it once, you're just sort of cursed and you're going to do it again. Whatever it is that makes you prone to a C. diff recurrence remains a problem for you. And after one recurrence, people get second and third and fourth recurrence. It's common. It's this endless cycle. People get sick. They lose weight. It's really a big problem. And that's where FMT has really been a lifesaver. I do want to talk for literally 2 slides about testing, because it can be complicated and it's still in flux. So you need to know kind of the take home, the condensed version of C. diff testing, and I'll make it very simple for you. We don't culture C. diff, period, the end. You're never going to get a C. diff culture. Do not send one. It won't happen and it's irrelevant. So that's something we do in research only. You essentially have 3 named C. diff tests on the market. The bottom 2 are typically sent together. Most labs now do what's called a 2-step algorithm, where what they first do is the test on the bottom. It's called a GDH. GDH is very fast, very inexpensive, and very sensitive. It is hyper sensitive. Not specific at all, horrible specificity, but highly sensitive, meaning, and super fast and super cheap, meaning a negative GDH and you're done. So the lab does that because it's just practical to do that. They can run a GDH in 5 minutes. If a GDH is negative, dispose of the specimen, you are done. That patient does not have C. diff. If the GDH is positive, it then gets reflexed to a PCR. We also call them NATs or NAATs, nucleic acid amplification test. And that is also very, very sensitive and is more specific. But I will stress, nucleic acid testing and PCR testing is not specific. It is sensitive, but fairly non-specific. And if you know what PCRs are, they're measuring bug DNA. They're measuring minute fragments of bug DNA. And now we do these multiplex panels where you can send someone off for a firefall, whatever those fire things are, BioFire panels where you get 20 or 30 different PCRs. It's just literally wash across a sample of PCR binding, and PCR binds to extraordinarily low amounts of DNA. So you can be colonized with C. diff and have a positive PCR test. It is not a test of active infection at all. Now, in the right situation, that's the perfect test. My grandma gets a UTI, she gets Cipro. A week later, she's got fulminant diarrhea. She shows up at the ER looking like shit after a week of Cipro. You don't even need a test, frankly, but if you did test her, a PCR is perfect. Of course, she has a very high prior probability of having C. diff. You can get that positive PCR back in a half an hour in the ER, and that's an adequate test for her. However, once someone has C. diff and once someone is treated, I would discourage you from using PCR testing. It is, as I said, very, very sensitive, but not specific. And you can get, again, it's a marker potentially of colonization rather than active infection. And once someone has been treated with C. diff, we strongly suggest that they get a harder test to get, because it's not the default test in anyone's lab. If you just order C. diff, you are going to get a GDH into a PCR. You need to order a toxin EIA or IA. Quest calls it an IA, I believe. LabCorp calls it an EIA for enzyme-linked immunoassay. That is an immunoassay for active toxin. It's not measuring minute microscopic amounts of DNA. It is measuring actual presence of toxin. Not as sensitive, that's a problem. Its sensitivity is poor. However, it is much more specific than a PCR. And in a post-treatment challenging case, do not trust a PCR. Index diagnosis, perfect for PCR, but subsequent testing and analytics, I would encourage you to specifically order a toxin EIA in that setting. So that's testing kind of 101, although there is something new I've told you, I tease you about future stuff. And here's the future stuff. We've got a new test for C. diff. And believe it or not, it's a PET scan. We are now doing PET scans for C. diff. And well, here's the PET. That's Clifford. That's actually Clifford. That is his name. And he is a beagle in Holland. And Clifford was born out of a, literally and metaphorically, out of a perception that we've known for years and years and years that nurses know C. diff. Nurses for 30, 40 years, nurses will tell their doctors in a hospital who's got C. diff because of a smell. There's a sort of perceptible, identifiable smell, and they've known that for a while. Well, if a nurse can smell something, Clifford the Beagle can smell it better. They have 1,000-fold better sensitivities, of course, than we do. So the Dutch trained Clifford to check out C. diff, and they walked him around the hospital, and boy, does Clifford's good, man. Clifford is frankly as good as the lab, if not better than the lab. Clifford is very sensitive, highly specific, actually. And in fact, there were a couple of false positives that were lab negative. 2 of them got C. diff later, and the thesis that it wasn't really a false positive. It was an early positive, and that Clifford was better at it than the lab was. And that's actually plausible. You don't, of course, have access to Clifford very easily unless you go to Holland right now. But anyway, that's that. Liat kindly mentioned the guidelines, and there are guidelines to this that just came out this year, or last year rather, within the past year. And these are there are 7 authors. I was one of them, and I didn't put my mug up there with you, but these are the 6 people I got to work with, and they're all wonderful people. And we wrote, I think, a good document that's worth reading. I'll highlight some of the take-homes from it. Of course, with prevention of C. diff is ideal. I would love to not have a job if you could prevent everybody from getting C. diff. And the way to do that, of course, is use less antibiotics, particularly use less quinolones. Quinolones are horrible. I really do hate quinolones for a lot of reasons. This is a person-to-person infection, as I mentioned, so isolation is important. Hand hygiene and contact precautions. We are vectors for C. diff. True, whether you like it or not, every one of you on the phone is a potential vector for C. diff. That's why gloves and hand washing matter. And then I'll tell you, unfortunately, alcohol-based hand sanitizers are useless for C. diff. They are wonderful for a lot of things. They are useless for C. diff. Things that kill C. diff spores are numbered 2. 1, soap and water. 2, bleach. Not alcohol-based hand sanitizers. They do not work. Prevention of C. diff with probiotics. I mentioned saccharolarity, and there's some evidence that might be beneficial, but not enough that our guidelines recommended it. So there is some moderate evidence, but it didn't rise to a formal guideline recommendation. You may be aware that PPIs are possibly, if not probably, a risk factor They are biome destructive. Acid is an important antibacterial. C. diff spores can be killed by acid in our stomach, but if you are hypoacidic on a PPI, you may be more at risk for that. And if someone needs a PPI, they need their PPI, but we're very aggressive about stopping unnecessary PPIs, certainly in a C. diff patient. You got 3 antibiotic choices on the market today for your C. diff. Flagyl on the left, very inexpensive. Vanco in the middle, relatively inexpensive. And of course, the newer one, Difficile, which is very expensive. Oh, it's $4,000 or $5,000 for a 10-day course, a very expensive antibiotic. The guidelines are pretty clear. If you have an initial episode of non-severe C. diff, 1, stop the antibiotic. 2, try to avoid Imodium. 3, you can give someone antibiotic. My grandma that I mentioned in the ER, honestly, if the lab was down and you couldn't get a C. diff test on her, treat her. Of course you should treat her. She has C. diff. Vanco or fidaxomicin are both recommended as first-line therapies in that guideline. And in a mild to moderate case, Flagyl still has a role in a healthy-ish person. Anyone on this call probably would be a candidate for Flagyl. My grandma with heart failure and on dialysis, no, she's not a candidate for Flagyl because you can't be wrong. In her case, she should get Vanco or fidaxomicin. But youngish, healthy-ish, outpatient-ish patients can still get metronidazole. It costs nothing. It is a rational approach, particularly in an area of constrained resources. If you have severe C. diff, we don't let you get Flagyl, so that's only for mild disease. It then becomes Vanco or fidaxomicin, although the data for fidax in severe illness is poor. All the trials in fidax were done in moderate disease, not in fulminant or life-threatening illness. So it's logical, but in fact, it's not necessarily evidence-based, and we call that a conditional recommendation. Vancomycin is more evidence-based in that population. And for fulminant infections, that's someone in the ICU basically, early surgical consultation, watch for a megacolon. We often will use higher dose Vanco, although you should be aware there's really not any good data that higher dose Vanco is better than lower dose Vanco. That's aspirational. It feels good to do. Oh, good, you're sick, so we're going to give you a really big dose of Vanco. And the good news is Vanco is not very toxic. But if you want to find some data that suggests that's better, you won't find it because it doesn't exist. We often give IV Flagyl in a sick patient. IV Vanco does not penetrate the colon. You cannot use IV vancomycin for C. difficile. You can use it, but it won't do anything because it does not get colonic penetration. However, IV metronidazole does actually, so that's another use pattern for Flagyl, IV Flagyl in a very sick patient. And then sometimes we'll also use vancomycin enemas. There's some science in the support of that approach as well, because all of this is basically trying to avoid them losing their colon, which does happen. There's a new body of data. Monica Fisher, who's in Indianapolis, is really the leader in this particular field, which is kind of fulminant ICU FMT. And there's a couple of papers out looking at doing sort of repetitive ICU, FlexSig, if you will, FMT for fulminant C. diff. And the data is good. Seems to save surgery and seems to work reasonably well. So that's something to consider in that population. And then I'm going to move from that population because that's not really, I mean, you guys as fellows will see that, but in fact, most of us in practice aren't seeing that so much. What we are seeing are these patients who walk in the door with, they got C. diff, they got vancomycin, they got better. A week later, they're back. They got C. diff, they got vancomycin, they got better. A week later, they're back. And that cycle is super common. I don't think that's what I see literally every day in my practice, but I suspect you're seeing that as well. That's a very, very common cycle. And we think the spores have a lot to do with that. We think that what we're really doing is killing the vegetative bugs with that Vanco, but what we're not doing is basically being sporicidal. We are being bactericidal, and the spores then wake up. I'm not going to spend time on it today, but in fact, your body can make some antitoxin C. diff antibodies. They're not helpful. They don't seem to be helpful. We don't measure them clinically. They're not useful, but it turns out people who get recurrent C. diff seem to have a lowered antibody response to C. diff. They have less antitoxin antibodies than patients who get one C. diff attack. Recurrent attacks seem to be related to a sort of lack of an immune response. And that population also has less biome diversity. I showed you that before. And maybe reinfection, but we actually don't think reinfection is the dominant form of recurrence. If someone recurs, this is from the guidelines, you got a couple of choices. You can give them fidaxomicin if they had Vanco first, or Flagyl, or you can do what most of us do, which is basically this tapering pulse dose of Vanco with a second or third treatment. And the logic of that is entirely, again, based on the spores, right? That's why we're doing that, because when you give someone Vanco, you're killing the bug, you're not killing the spores. And what I do with my pulsed regimen or my tapering regimen is I give people days off. I do not do QID, TID, BID, QD. I think that's actually useless, because I still think you're not letting your spores wake up. The point is to withdraw the DUG, allow spore germination, and then retreat someone. It's not unanalogous to how we treat pinworm, right? If you've treated pinworm, you know you give someone mebendazole or Vermox, and you're killing all the worms, but you're not killing the worm eggs, right? So you got to give them, you got to wait 2 weeks, let the eggs hatch, and get your patient in a window where the eggs have hatched, but they haven't laid more eggs yet. And then you give them another dose, and now you've killed the bugs that hatched. It's kind of what's going on with C. diff. It's not worms and eggs, of course, it's spores and bacteria, but you're withdrawing Vanco, you're letting some spores germinate, and then you're treating with Vanco again. You're withdrawing Vanco for a couple of days, for 2 days, for 3 days, for 4 days. You're prolonging their Vanco-free interval, and then you're hitting them again with Vanco to treat the spores that are germinating. These are things that you should be aware of. I have right now a handful probably. You're looking at my back window. There's actually a nursing home right there called St. Paul Towers. I probably have a dozen patients in St. Paul Towers right now, and I probably have 1 or 2 of them who are sort of long-standing C. diff patients. And sometimes they live on a Vanco a day, and that's not the end of the world. And someone with a short life expectancy who's not a candidate for FMT, 1 or 2 Vancos a day is not horrible. Ototoxicity is probably the one thing to be aware of, but it's not a horrible risk. The other thing now, there's some data in support of, and I've been doing for years, but it's nice to have some data behind, and we call it OVP, which is oral vancomycin prophylaxis. And what that means is back to my grandma, she gets she got a UTI, she got Cipro, she got C. diff, we fixed her. Now she's going to get she gets a UTI again because she's a 90-year-old lady. So she's going to get another UTI, and they want to give her more antibiotics for her damn UTI. And she says, grandson, what am I going to do now? And my answer is take Vanco simultaneously with that Cipro or that Bactrim or whatever she's getting for her UTI. So simultaneous administration of vancomycin with subsequent antibiotics in people who have had multiple recurrences of C. diff seems to be effective and beneficial. And I do that routinely for people. We can talk about that more later if you want, but we're going to spend the rest of this time closing and talking really about FMT, because this is really the fix that we're going to talk about today. As you know, FMT basically means taking whole stool, right? So this is not a defined, it's not a probiotic. It is whole stool from a human who you believe is healthy, putting it in a human you believe is unhealthy with the intent of making that other human healthier. That has been described for millennia. It's an old Chinese medicine text. The vets have been doing it for hundreds of years. 1908, Journal of Equine Medicine. Horse A has diarrhea. Stick your arm up horse B's tush. Grab some horse B poop. Put it up horse A's tush. Horse A gets better. Described over 100 years ago. Fecal transplants in horses. Probably the earliest modern human fecal transplants were reported in 1958. A surgeon in Denver named Eisenman who had patients with pseudomembranous colitis. They didn't know about C. diff, by the way. It was pseudomembranous colitis. It almost certainly was C. diff, but he gave enemas to 4 patients on the surgical ward who had this pseudomembranous colitis from, I don't know if it was surgery interns or nurses, I forget who they used. It was some staff in the hospital. They made up enemas and they fixed 4 people with pseudomembranous colitis. And that probably was the sort of first modern report of that. The FDA in 2013 came along and said, wait a minute, Neil and Christine and Larry and Colleen and all the rest of you, what the hell are you doing? We said, well, this is what we're doing. And they said, okay, you can do that. And they have adopted a written policy called, quote, enforcement discretion, which basically means for recurrent C. difficile and recurrent C. difficile only, you can do FMT in that population after they failed standard traditional therapy. And our guidelines address that, and we overtly recommend FMT in our guideline. That is a strong recommendation with actually, I'd say, very strong data now for patients experiencing their second or further recurrence of C. difficile infection. FMT is essentially guideline supported for that. And while it's not FDA approved, FDA is doing this sort of wink and a nod. It's published. They write it down. They basically say, okay, we don't know what to do. You can do it for now. That will change one day. If you want to learn more about FMT, I'd refer you to this article that I was not a co-author of. This is Jessica Allegretti in 2018, where she talked about the 5 Ds of FMT. And then she put that into a book, which I am a co-author of, which is the 6 Ds. And I don't even know what the extra D is, but we bought another D, and there's now a textbook, a small little paperback textbook called the 6 Ds of FMT that you can buy. That is kind of a primer on a how-to do an FMT. And I'm not going to do stuff with that today, but you are aware there's a bunch of ways to get poop in someone. You could put it in an NG tube. You could put it in an enema. You could do it the way I typically do it, which is colonoscopically. And pills, of course, are common. Poop pills or crapsules, as we like to call them. That's the holy grail here, right? We all want pills to be the answer. Patients want pills to be the answer. If we can get effective, inexpensive pills, that will be the answer, but we're not there yet. This was just a meta-analysis looking at different modalities of administration, and I will just show you that single dose enema does not work as well. Freezing doesn't seem to matter, but pills seem to work, and colonoscopy is probably the best. And in fact, I don't have the study I wanted to show you. Why does this all work? Forget the graphs. You don't have to spend much time looking at this, other than you'll have to believe me, and that there's insanely good data that it engrafts, that however you put that poop into someone, above, below, rectum, cecum, ileum, it engrafts. And this, for example, in the middle here is your donor, a lot of orange. In this case, orange is Bacteroidetes. To the left here is your patient, basically no Bacteroidetes, no orange. Your patient looks like this. Your donor looks like this. This is your patient in 2 weeks. Looks a whole heck of a lot like your donor. This is your patient in 4 weeks. Still looks a heck of a lot like your donor. On the graph on your right, it's a different trial, but the donor's got a lot of green and blue. The recipient's got a lot of red. 2 weeks later, the recipient looks like the donor, a lot of green and blue. And it doesn't matter what they are. You can look, they're labeled for you. Again, it's largely Bacteroidetes and Firmicutes, but you can make the donor look like, you can make the recipient look like the donor. This absolutely works. This is just another study looking at 3-month engraftment. There's endless data to that point. And this gets at the thing I mentioned earlier, which is just the diversity thing. So here, your donor, very higher is more diverse. This is the Shannon Diversity Index. Higher numbers are more diverse. Your recipient is not diverse. Your donor is diverse. And here's your recipient at 1 week, 2 weeks, and 4 weeks. Very diverse. This trial also looked at fresh, frozen, and freeze-dried, and they all worked. Basically, there was no distinct difference. Freeze-dried was maybe a little bit less. We're not sure. But fresh, frozen, and freeze-dried all seem to be effective and improve diversity. This is a trial from 2012. So my prior trial, this was my second trial. This is me and Chris Sorowitz and Larry Brandt and Colleen Kelly. And these are our first 77 patients, open label case series, not great data, but basically our first 77, 10 years ago now, our first 77 FMTs, 9 out of 10 were cured with one FMT, 98 out of 100 were, or 90, 75 out of 77 were cured with a second FMT. No one got C. diff back unless they got more antibiotics at all. We looked for AEs and long-term AEs, and I will tell you, we didn't see anything dramatic, but we did. Now it's 74 patients, but 77 patients, but 4 of them subsequently developed autoimmune diseases. They were all women, middle-aged women, in fact, who are sort of entitled to develop autoimmune diseases, so to speak. But it's also theoretically possible that that FMT is an antigenic stimulus and is somehow causing, in fact, that may be part of how FMT works, is by sort of an immune stimulation in a population of people who are not responding immunologically to C. diff. FMT may well enhance that response. And while that's a good thing to get rid of the C. diff, if you are prone to autoimmunity, that may not be a good thing. And we can talk a little later about IBD too. And in some small subset of patients, FMT can cause IBD flares, probably by a similar process here. That's 2012. A year later in the New England Journal comes this study, the Dutch study, which was a nasoduodenal study, a kind of horrible design. It was stopped early. I think it was stopped early for ickiness, but in fact, they say it was stopped early because they said it was so effective that it wasn't ethical to continue. They literally stopped the study because this is one FMT, this is 2 FMTs, this is Vanco alone, and this is Vanco plus a lavage. They were concerned that the bile lavage might be beneficial. It wasn't, but that was a thought process. And you can see 80% better with one infusion, 94% better with a second infusion. And they stopped the study because they said, how can we give people anything else? This basically works. So I think that's kind of when FMT arrived. When you land on the cover of the New England Journal, in my mind, that's the day you you arrive is that's not my trial, but and I've not yet been on the cover of that New England Journal, but that's kind of when we arrived. I've got a daughter. She's a TV-aholic, or was, and she decided that FMT was real finally when it was done on Grey's Anatomy. And I'd like to think they modeled it on me, that McDreamy is a clear one-to-one transliteration of me into this fellow here, McDreamy, as my daughter calls him. It was an absurd plot line. I was not a consultant to that story. It was, they were called stat to the ER. I'm not joking. The patient showed up in the ER with severe C. diff, and they went to the ER and did a stat FMT in the ER and discharged the patient home an hour later. And that would be a great thing to do if we could do it. That, of course, bears no reflection to reality, but that's the TV reality of an FMT. However, there's also a more recent TV reality of FMT. And while you may not think of South Park as a bastion of scientific accuracy, in point of fact, they were better than Grey's Anatomy. Their depiction of FMT is more consistent with life than that episode is called The Turd Burglar, I believe, and I would encourage all of you, if you've not seen that episode, it's an excellent primer. You could buy Jessica's book on how to do FMT, or you could watch Turd Burglar episode of South Park. This was in the Annals a few years ago. This was a US randomized trial that Colleen Kelly and Larry Brandt did of FMT. The control arm was was sort of autologous FMT, not sort of, it was in fact their own poop. It was autologous FMT. The response rate was 90%. There's a problem in this trial, which is that the placebo response rate was high, and that's because basically it was a really, really, really slow trial, and these people stayed on Vanco for 3 to 6 months before their FMT, and it turns out if you stay on Vanco for 6 months, you'll probably cure some C. diff, actually. But that was kind of a flaw in that trial. Lots of this data now. These are reviews from 2019, the most recent. There's more since then, and they all show the same thing basically. Lower FMT is 90+% effective. Upper FMT is probably 80% effective. Upper being pills or nasoduodenal tubes. Pills are still have less data in support of them. I don't think there's any question in anybody's mind that this is an effective therapy. The science is unequivocal at this point. FMT works for multiply recurrent C. diff. I think that is a true statement, and I can say it confidently. Just FYI, after an FMT, we stop vancomycin, of course, and all other antibiotics. This comes up all the time. Please, please, please. Patients want to test. They want to know they're negative. Their primaries want to know they're negative. It's common that my patients get their FMT, and then 2 weeks later, someone sends a damn PCR C. diff on them, and it's positive. They're not having diarrhea. They're having normal bowel movements. They feel great. That's not a useful result at all. If a patient has symptoms, you should retest them. If you retest them, you should retest them with a toxin EIA assay, not a PCR NAAT assay. But honestly, you should not be testing them unless they have recurrent symptoms. Unlike, for example, H. pylori, where we insist on a test of cure, C. difficile is the opposite of that. We do not mandate test of cure. In fact, we strongly argue against that. There's increasing data on FMT in special populations. I published a report with some of my other co-authors on a whole bunch of, I think 70 or 80 immunocompromised people, and they did fine, actually. We didn't have any bad outcomes in our population of, quote, immunocompromised patients. That being said, I should tell you there has been one very well-publicized death with an FMT in an immunosuppressed patient, and it was actually published, I think, New England Journal. They published it as a case report. It was at Harvard. It was in a study. It was a cirrhotic patient who was immunosuppressed as well, I believe. And they got a multi-drug resistant organism, an MDRO, that we were not checking for. But that being said, being on chemotherapy or being on IBD meds is not a contraindication to FMT at all. Kids, we don't know a lot about yet. Pregnancy, we don't know a lot about yet. I mentioned sort of prophylactic Vanco and long-term maintenance Vanco as well. This is a couple of things just to be super, super, super aware of. The first thing is a fascinating study that kills me. It's wonderful. It's a lousy study, but it raises so many questions that we haven't answered yet. 5 patients with C. diff, so ridiculously small study, but who got FMT via NG tube. So again, a ridiculous kind of thing to do. But they basically filtered out the bacteria from the FMT. They killed the living bacteria. The material that was implanted did not have living bacteria in it. 5 out of 5 of them were still cured. Fascinating. And that raises the really cool question about what's in stool and what matters in stool when you're doing an FMT. Maybe dead bugs are good. Maybe that helps set your milieu. There are certainly viruses and metabolites and bile salts and phages and all fungi. There's all sorts of other stuff in stool. Stool is not just bacteria. And is it possible that it's stool but not bugs? Maybe it's not bacteria per se. We don't know that at all. So just, I want you to keep an open mind that we know nothing about this, really. We know so very little about this. The other thing I want to tell you, excuse me, all of us in GI know about post-infectious IBS. We see that all the time. That is true and nowhere more accurately than in C. diff. These patients have had the recurrent C. diff patients have been sick for 6, 9, 12 months. After you fix their C. diff, they are not normal for another 3, 6 months. They are not. They have IBS. It's common. I actually have a boilerplate thing I send them home with that talks about it. And you have to be mindful that they're going to have some symptoms, and you have to be just, it's kind of like your IBS IBD patient. It can be hard to distinguish their IBD from their IBS, and you can use calprotectins in that population. You can use testing in this population, but really good study that looked at patients who were PCR positive but EI toxin negative, enzyme toxin negative. They were the same as negative patients. They did not do any worse. Colleen, I think it was Colleen's clinic, wrote this up. They had an FMT clinic. 25% of people who were sent to them for FMT didn't have C. diff, or they didn't think that was the problem. It was IBS and a colonized C. diff bystander. That is very, very common. So be mindful of that. I mentioned the death, and that's important. We don't know enough about safety yet. I think the assumption is this is unsafe, and I think that's the right assumption. You should not be assuming this is riskless. It is not riskless. Obviously, if you're doing colonoscopies, people can have colonoscopy-related complications. People can certainly have aspiration. People can certainly get perforations. And as I mentioned at the bottom, are we turning on an immune response in a well-intentioned benefit in their C. diff, but maybe not so well-intentioned for their subsequent health? And it's a low number, 5, 10, 15%. But when you do FMT in IBD trials, there is a population of IBD patients who flare. And that may well, I think that subset is due to this. People are doing FMT at home, and I get asked that question every day by patients. This was a publication on that. It was an online survey. Most of them were doing it on themselves, although some people were doing it on their kids. They were all getting it done on the internet. They were all very frustrated because they weren't getting anything done. I'm sure a lot of them had IBS or IBD. Most of them knew their stool donor. Most of them did it with enemas because that was a way to go. Almost half of them had done it repetitively, including more than 10. Those are the indications, basically: IBD, food allergies, IBS, SIBO. 10% said they had some symptoms, basically. 80% said they got better, and everybody said they would do it again, but they all wanted to do it with docs. So if we can do this for people, we should. These are not people hiding from us. They're people who we're not helping, basically. So they're doing it on their own, and that's a thing. So you're shortly going to get some bugs. You're going to get some products, rather, on the market for this. Maybe this year, certainly I suspect by next year. And you should understand they really run the gamut from what I would call the least manipulated product. These are basically whole stool, right? To the most manipulated, which at some level is a probiotic. And where is the dividing line in between these two? There is no such line. And that's a fascinating question, frankly. When does a probiotic become stool, or when does a stool become probiotic? There are 3 products that are in very near-term development. Rebiotics has a whole stool product. That's really all it is. It's in an enema. And that will be, I think they might have applied for FDA approval. I think they have. They haven't gotten it yet. But it's poop. It's not anything different than that. And it's going to come in an enema bag. And they have some moderate data. And that may come on the market shortly. Another company called Series has a collection of ecospores. That's their term, not mine. It is a narrow spectrum product, so it's not whole stool. It is a selection of spores that they think are the right spores and put in a pill. And their most recent data showed a reduction in recurrence from 40% with placebo. Whoops, sorry about that. to 12% with the product. So that was a good outcome. 40% recurrence, which happens to 12%. So that's coming. That'll be a pill product after treatment for C. diff. And Finch is what the Open Biome sort of turned into. Open Biome is a stool bank at Boston and MIT, still exists as a nonprofit. They spun out a commercial company called Finch, which is commercializing a pill of whole stool. So that is, it will be a capsule, but it's a whole stool product. And that is coming as well, although the trial got put on hold for COVID issues, and we're not sure when we're going to see those results. So those things are all coming. This was just the data on those Firmicutes scores. And you can see placebo was 40%. The product SER 109 was down to 12%, and that's absolutely good. There's nothing wrong with that. FMT, of course, is being looked at for other things, lots and lots of other things. And they're listed here. This was just a clinicaltrials.gov search I did a little while ago. Lots and lots of things going on looking at this. The dominant ones are IBD, ulcerative colitis particularly is being looked at. IBS, we'd love this to work for, but there's a lot of different IBSs out there, as you know. Being looked at for graft versus host, that's an interesting one. HIV, diabetes, multi-drug resistant organisms, that's an interesting one. Hepatic encephalopathy is interesting. ASD, autism spectrum disorders are being looked at. ICI resistance is an amazing topic if we had time to talk about, immune checkpoint inhibitors, which are really effective for a certain number of cancers like melanomas and renal cancers and the like. Turns out that response to immune checkpoint inhibitors is really dependent on a biome profile, and some people have a great biome, respond well. Some people have a bad biome, respond poorly. And the holy grail there is, can we put in a biome that makes you more responsive to chemotherapy? That's not pie in the sky at all. That's actually coming. And then there's this cool one down here is, can you bank your own stool? And I don't think that's crazy at all. We have a sperm bank and an egg bank, and you can bank your own blood before surgery. You can do autologous blood banking before you're going in for surgery. Why not spend $100 and send some, you're healthy now, you're 25-year-old, you're not sick, you haven't had antibiotics in 5 years, keep it. You got good poop now. Nothing wrong with keeping it in case you need it later. So a lot of unanswered questions and future directions. I'm going to stop here, but we don't really know how to give this to people. We'd like to give it to via pills. That's probably the right answer. We don't yet know, is it just a healthy kid at MIT? Is it a rational donor? I didn't really talk about that, but are there better and worse donors? And that's a fertile area of research looking at sort of super donors. Is it whole stool or is it a synthetic stool, a subset of stool? Is it bacteria or is it other things besides bacteria like viruses or fungi? Is it for C. diff or other things beyond C. diff? Clearly, this is the template, and that's what really excites me about this. Forget C. diff for a minute. It's a lot of what you and I do with what we do because we're us. But for the rest of the world, they don't give a shit about C. diff. C. diff's a tiny little thing on the big planet of ours. But biome restoration is not a tiny little thing, and I think we should think of this as the sort of. I really do think this is the beginnings of microbiome management. I titled this lecture appropriate. And you may ask, of course, what is the future of feces? And if you live in the East Bay and you got the East Bay Express, well, apparently a few years ago, was deemed to be the future of feces, to the incredible mortification of my teenage daughter, that her dad was on the cover of the paper with literally the word feces on his chest. I cannot think of an uglier word in the English language to emblazon in a Superman font on my chest. And that was a fine parental moment for me. And with that, I'm going to stop, and I'm going to stop sharing my screen. And I got some time for questions for anyone who wants to hang out and ask them. I appreciate the invite. I appreciate your hanging out and listening to me. And thank you very much. Questions?
Thank you, Dr. Stollman. That was fantastic. All right. Does anyone have any questions at this point for Dr. Stollman? I know we're a little bit over time, so we also want to be respectful if people need to hop off.
Thank you, Maria.
So,
hey, Paul.
I had Dr. Stollman, I feel like, so the drug rifaximin that we're using a lot for SIBO, IBSD, any thoughts about the impact of rifaximin on the microbiome and the diversity of the microbiome and how that, may be affecting people?
Yeah, it's an important question, but I don't think we have a good answer for it yet. You may be aware that actually rifaximin has been purported as a C. diff treatment. I don't think it's a good one, and I've not had success with it, but there are a couple of small series of what they've termed a rifaximin chaser, which is you give someone their standard therapy with Vanco or whatever you're giving them, and then you follow that with a 10-day course of rifaximin. That was arbitrary and made up, and there's one very small report that suggests it works. There was another study I saw that suggested it didn't work. And by the way, there absolutely are reports of rifaximin causing C. diff. So is rifaximin C. diff treatment? Is rifaximin C. diff etiologic? Yes, it is. And you know, it is one of the dominant arguments I use when I talk to patients against SIBO treatment. We all, again, any of you enter the private world, you're going to have that conversation every single day about a patient who wants their SIBO treated. They're certain that's their problem. They read it on the internet. The only thing that's clearly wrong with them is SIBO. And if all we could do is get rid of their SIBO, boy, oh boy, would their bloating get better. And that's a conversation you're going to have all the time. And you're going to have to decide, do you surrender to that conversation and write a prescription, or do you, in fact, do something that I think takes longer, but is probably better, which is explain to them that they probably don't have SIBO. They probably don't have a risk factor for SIBO. If they're not a Parkinson's, diabetic, you know, whatever, they're a young, healthy 25-year-old, they probably don't have SIBO. And even if they do, the testing is fairly inaccurate, as we well know. And the treatments, of course, are almost always evanescent. And they're highly biome disruptive. It's antibiotics. And that's my strongest argument against sort of throwing rifaximin at nonsense. At IBS, basically. Again, I'm sounding like an old man here, but I don't think it fixes people. I don't think it's rare that I see durable response. You see a placebo response. You certainly see a short-term response. I don't see durable response to that agent and that thing, and I find it frankly not very fruitful as an avenue of therapy. But so I discourage it. It's a long answer, Liat, to a short question, but bottom line is I try to discourage it. Now, hepatic encephalopathy, you need your rifaximin. There's clear-cut outcomes data that it's beneficial. We'll deal with your biome. That's, you know, I think that's okay. And there's actually some fairly encouraging data that it's not, that population is not having sort of horrible biome consequential things. So I'm sort of pro-rifaximin in a very narrow therapeutic indication. I'm anti-rifaximin sort of for the aspirational SIBO treatment.
Yeah, no, that makes a lot of sense. Thank you so much. All right. Anybody else? Well, thank you again, Dr. Stollman. That was really a fantastic talk. You covered so much information. So I know everyone learned a lot tonight. Thank you again for your time and, you know, for taking the time to talk with all of us. We really
you got it. My email, everybody, is, I don't know if I put it on my first slide, but it's neil@stollman.com. It's a pretty easy thing. You're welcome. If you have any questions, you can absolutely send me that. And
Dr. Stollman, it's Michael
Hey,
Alper
Mike.
from Fresno. How are you doing?
Hey, Mike. And Mike, before one quick thing before people get off, I'm in a practice in Oakland, and if any of you are graduating at some point and looking for, I got turned down recently from a fellow I was trying to hire, and they decided to take a different job. So I have a not an unexpected. I had one of my partners just retired, and at some point slowly, Dr. Mike Darby, if those of you knew him, a wonderful fellow, he just retired. So at some point, my practice in Oakland is going to be looking for another partner. Some of you may know my other partners, Susie Cohn, who was at UCSF, and Leanne Ledesga, and Paul Chard, and we have a good group in Oakland. And if any of you who are fellows are graduating, use that email. Sorry, Mike, I interrupted.
No, it's okay. It's okay. No, it's good. Quick question. There was some Merck product for C. diff, but not for the treatment. I think for prevention after you treat. I thought it was a infusion.
Yeah, so I took it out of my talk. I have a slide on it, but bezlotoxumab is the chemical. It's a monoclonal antibody against C. diff toxin. It's marketed as, doesn't matter, it's bezlotoxumab. It's a single dose infusion after C. diff treatment, contraindicated with heart disease, which is a big problem because a lot of these people are old with bad hearts. In data, in a New England Journal published report, it dropped recurrence from about 27% to about 13%, about a 50% reduction, which is not nothing, and probably worth something, but difficult to use. It's an IV infusion. It's very expensive. It has contraindications, and its magnitude of benefit is not gigantic. That's not to say it doesn't have a role, and I have used it a couple of times. I don't think it's a game changer in this field at all, but it's a Hail Mary. It's a reasonable Hail Mary for a really tough patient.